Cerebral hemorrhage. Etiology and pathogenesis. Hypertension and arterial sclerosis. Atherosclerosis, bleeding tendency, hemophilia, leukemia, aplastic anemia, thrombocytopenia, congenital angiomatous malformation, arteritis, tumor. Lenticular striate arteries vertical to MCA. Microaneurysms rupture. Pathology. Site, basal ganglia, 70%, brain lobe, brainstem, cerebellum. Lateral hemorrhage, the bleeding is confined lateral to the internal capsule, lenticular nucleus, external capsule. Medial hemorrhage, thalamus. Hematoma edema herniation. Hematoma stroke capsule. Clinical feature age, 50 to 70 male greater than female. Occur at physical exertion or excitement. Sudden onset of focal signs. Usually accompanied by headache and vomiting. May have consciousness disturbance. Clinical feature 1. Putamen hemorrhage. Contralateral hemiplegia, hemianesthesia, and hemianopia. Eyes are frequently deviated toward the side of the affected hemisphere. Aphasia if dominant hemisphere is affected. Clinical feature 2. Thalamus hemorrhage. Contralateral hemiplegia, hemianesthesia, and hemianopia. Deep sensation disturbance. Ocular signs. Disturbance of consciousness. Clinical feature 3. Bonton hemorrhage mild, crossed paralysis. Severe, greater than 5 milliliters. Coma. Pinpoint pupils. Hyperpyrexia. Tetraplegia. Die in 48 hours. Clinical feature 4. Cerebellar hemorrhage. Occipital headache, intense vertigo and repeated vomiting, ataxia, nystagmus. Severe cerebellar hemorrhage, coma, compression of brainstem, tonsillar herniation. Clinical feature 5. Lobar hemorrhage seen in AVM, moya disease. Headache, vomiting, neck stiffness. Seizure. Focal signs. Investigation 1. CT first choice high density blood. Mass effect and edema. High density isodensity low density. Investigation 2. MRI brainstem hemorrhage. Less than 24 hours, not distinguishable with thrombosis. 3. DSA. Young and with normal blood pressure. 4. CSF. Bloody. Done only when the CT is not available and without increased ICP. Diagnosis age greater than 50, with hypertension. Sudden onset of headache, vomiting, focal sign. Occur at physical exertion or excitement. CT, high density blood. Differential diagnosis. Coma, poisoning, hypoglycemia, hepatic or diabetic coma. Focal signs, cerebral infarction, brain tumor, subdural hematoma, SAW. Treatment 1. Keep rest, monitoring, airway, good nursing. 2. Keep electrolytes and fluid balance. 3. Reduce ICP. 20% mannitol 125 to 250 milliliters, 3 to 4 times per day. Furosemide, albumin, dexamethasone treatment. 4. Control hypertension, less than 180/105 of a millimeter of mercury in acute stage, ACE, beta blocker. 5. Prevent complications. Infection antibiotics. Gastric hemorrhage, cimetidine, Losec. Venous thrombosis, heparin. Treatment 6. Surgical therapy. Putamen, lobar, greater than 40 to 50 milliliters, deteriorating. Cerebellum, greater than 15 milliliters, diameter 3 centimeters. Thalamus, obstructive hydrocephalus ventricular drainage. 7. Rehabilitation. Subarachnoid hemorrhage SAW. Saw cranial bone duromotor arachnoid P hemotor brain lobe. Primary spontaneous saw. Traumatic saw. Secondary to cerebral hemorrhage, etiology 1. Intracranial saccular aneurysm. 2. AVM, arteriovenous malformation. 3. Hypertension and atherosclerosis. 4. Moyamoya disease. 5. Mycotic aneurysm, tumor, polyarteritis nodosa, bleeding disease. Pathology anterior cerebral and anterior communicating. Internal carotid. Middle cerebral. Bacillar. Clinical feature 1. Age of onset, saccular aneurysm, adult 30 to 60. AVM, juvenile. Hypertension, more than 60. 2. Prodromal symptoms. Warning leaks, headache, vomiting. Cranial nerve paralysis, oculomotor. Clinical feature 3. Acute saw. Sudden onset of severe headache, explode, burst, the worst of my life. Vomiting. Associated with physical exertion, excitement. Transient loss of consciousness or coma. Pain of neck, back, leg. Mental symptoms, apathy, lethargy, delirium. Clinical feature 3. Acute saw. Signs of meningeal irritation, neck stiffness, positive Kernig's sign. Fundus examination, papilledema, subhyaloid hemorrhage. Cranial nerve palsy. Clinical feature 4. Delayed neurologic deficits. Re-rupture, in first 4 weeks, again has severe headache, vomiting, unconsciousness, with poor outcome. Due to fibrinolysis. Cerebrovascular spasm, 4 to 15 days after initial saw, cerebral infarction, disturbance of consciousness and focal signs. Hydrocephalus, 2 to 3 weeks after saw, gait difficulty, incontinence, dementia. Investigation. 1. CT. Subarachnoid clot in 75% of cases. Investigation 2. CSF uniformly blood-stained. Xanthochromia, 12 hours to 2 to 3 weeks. ICP. 3. DSA, etiologic diagnosis, important to surgery. 4. MRA, CTA, diagnosis sudden onset of severe headache, vomiting. Neck stiffness, positive Kernig's sign. Uniformly blood-stained CSF. CT shows subarachnoid clot. Differential diagnosis. Cerebral hemorrhage. Meningitis. Tumor. Psychosis. Treatment 1. General management, absolute bed rest for 4 to 6 weeks. Prevent constipation, excitement. Sedatives and analgesics. 2. Reduce ICP. Mannitol, furosemide, albumin,